Welcome to Gracefully Graying. I'm your host, Attorney Henry Gornbein. Today on Gracefully Graying, I am very pleased to welcome neurologist Dr. Jonathan Fellows as he leads us in a discussion regarding the terrible disease known as dementia. Dr. Fellows, welcome to Gracefully Graying.
Thank you. Glad to be here.
First of all, why don't you tell us about your background?
I'm an adult neurologist. I work at MIND, which is the Michigan Institute for Neurological Disorders. We're on Orchard Lake Road in between 12 and 13 Mile. I wear a few different hats. I'm also one of the associate program directors for our residency program through Corewell Health. In terms of my day-to-day activities, I have some administrative roles at the office. I have administrative roles at the hospital, but really what I do most is I take care of patients. I take care of patients with all neurological diseases, but over the last, I'd say 6 or 7 years, I've sort of shifted my focus to more memory care. I lead Mind's efforts in terms of our Alzheimer's and memory care clinic. So we take care of patients with all different forms of dementia, but in terms of what we really can make an impact on in today's day, it's really Alzheimer's disease. So again, my primary focus is patient care, and that's what I do on a routine basis, Monday through Friday.
What are some key signs of dementia?
So dementia, as we know it, is an umbrella term. So underneath that umbrella lies the most common form of dementia, which at any age is Alzheimer's disease. Obviously, 65 and greater is sort of the age at which Alzheimer's really comes into play. But when we talk about dementia, that's the umbrella term, Alzheimer's always being number one, but there are other causes of dementia as well, such as which usually cause vascular dementia, now formally known as vascular cognitive impairment, and then Lewy body disease. That rounds out the top 1, 2, and 3 causes of dementia. But then there's also other forms of dementia like frontotemporal dementia, and also things like Parkinson-related dementia. We talked about Lewy body disease. There could be things under the umbrella of frontotemporal dementia like cortical basal syndrome or other forms of aphasia, what we call primary progressive aphasia. So there's many different forms of dementia, but a lot of times people tend to use the word dementia interchangeably with Alzheimer's, which is not all that incorrect, seeing as though most cases of dementia are caused by Alzheimer's disease.
Okay, I find it a little confusing, but I think you're helping. What are the tests used for diagnosis?
So it's not just one single test. First and foremost, we start with the history and physical examination. So first we want to bring the patient in, talk to them. What are the complaints that they're sort of experiencing? But it's not just the individual that we're concerned about. It's what others from the outside looking in are saying as well. Individuals like spouse, family member, children, close colleagues, work colleagues, things like that. We want to hear what other people from the outside looking in have to say about the individual as well. Certainly, we're talking about memory problems in terms of symptoms related to dementia. So we want to hear what other people see as well. So the history is very important. Then we do a physical exam, which comprises mostly our neurological exam, which we want to make sure we're not seeing any features referable to maybe stroke, because stroke or what's called vascular cognitive impairment, like I mentioned before, can be a reason for memory problems and things like that. Many times we'll do a bedside memory test. That could be something like what's called a MoCA, or Montreal Cognitive Assessment, or MMSE, the Mini Mental State Examination. This is something that many folks on your channel are probably familiar with because they've had them in relation to their Medicare wellness examination. That's one of the required tests, some sort of bedside cognitive test. It might just be repeating some words, drawing a clock, naming animals in a certain amount of time, things like that. But again, some sort of bedside cognitive assessment is really important, and that can help to guide us in certain ways in terms of the memory care evaluation. So history, physical. The next would be the bedside cognitive evaluation. If we don't think that's adequate, we can send out for what's called neuropsychometric testing, which would be adult memory testing. We send to a licensed neuropsychologist, and they do a series of sort of testing to test their cognition. It's usually several hours long. It's quite difficult, but it's quite meaningful in terms of the results that the neuropsychologist is able to give us a report on that. The next thing that we're going to want to do is some blood work. We're going to want to make sure that metabolically everything is okay, meaning kidney numbers are okay, liver numbers are okay, because there can be metabolic reasons why your memory isn't functioning quite as well as it once was. We're going to want to do not just the metabolic panel, but also other blood tests. In today's day and age, there are really good blood tests. Number one, to test the genetic risk of developing the most common form of dementia called Alzheimer's disease. But we can also do blood tests to check for whether or not there's what's called amyloid in the brain. And amyloid is that bad sticky protein that gets into our brain and again causes the most common form of dementia called Alzheimer's. So today we have really good, very accurate blood tests that both on the genetic end as well as testing for amyloid in the blood. So those are good opportunities that we can do. The next thing that we're going to want to do is some sort of brain imaging procedure, preferably an MRI of the brain, because again, we want to rule out any other causes for memory problems. Is there a stroke that's present? Is there a tumor? Is there what's called hydrocephalus, which is extra fluid on the brain? Again, these are all other causes other than things like Alzheimer's disease, but we want to rule those things out with some sort of structural imaging procedure of the brain. And then we may want to go to what's called a functional brain imaging procedure. And those are called PET scans. And there's two main forms of PET scans. One of them is called an FDG PET scan. That's a fancy acronym for basically a glucose PET scan. And glucose is the main sugar, the main energy source of our brain cells, our neurons. So we inject the individual with a sugary substance that is a nuclear material, and we watch under the nuclear machine how the brain sort of metabolizes that. And if you see what's called hypometabolism or decreased activity, that tells us that maybe, oh, the temporal lobe here or the frontal lobe here, there's certain areas that may have decreased glucose uptake, and that can help us in sort of diagnosing that individual with different forms of dementia. And then the last type of PET scan that's commercially available that we do on a very routine basis is called the amyloid PET scan. And the amyloid PET scan is a really helpful test because that's sort of the gold standard. We mentioned those blood tests before, but the amyloid PET scan is the gold standard at looking for whether or not there's amyloid in the brain or not. Highly accurate. And again, if amyloid is present in the brain, with the right clinical picture, that essentially equals Alzheimer's disease. Other tests we may want to do would be what's called an EEG, where we stick low electrodes on the scalp and we measure the electrical activity of the brain. We want to make sure that there's no slowing of the electrical brain waves, and we want to make sure that there's no irregularity or what we call focality, one side different than the other. In general, everything with neurology, we like the left and the right side, whether it be the brain or the body, acting very similar to one another.
What are some of the causes of dementia?
So causes of dementia, the most common form of dementia would be Alzheimer's disease. And many times there's not anything that the patient did wrong. One of the things that we really want to be careful about and really want to talk to the patient about would be concussions or closed head injuries, because those can really sort of turn on the switch, if you will, for if there's a genetic predisposition to forming a dementia, closed head injury and concussion can sort of be that precursor to that. And certainly individuals with multiple closed head injury or concussion over the course of their life, whether they be professional athletes or people that fall on a routine basis and hit their head, these are individuals that are absolutely increasing the risk for the development of Alzheimer's disease. Other sort of like risk factors, if you will, for developing dementia, including Alzheimer's, would be things like smoking or excessive drinking, sort of like bad habits, if you will. Poor sleep is a big one. Sleep is a tough one because on one hand, we don't want to give individuals very sedating medications to help them sleep because those can slow cognition and cloud the mind. But on the other hand, we know that sleep deprivation is a huge indicator and risk for either the development of dementia or making the dementia symptoms even more prominent. A big one that many of your listeners have probably heard about, no pun intended, is hearing loss. And hearing loss is a huge sort of risk factor for the development of dementia. There's a ton of research being going on right now in terms of the hearing loss world. And basically, anyone over the age of 65 should have a formal hearing evaluation to have their hearing checked, because we know that hearing loss is a risk factor for the development of dementia. There's a lot of different theories. The research is still out there. One of the theories is, if we're not bringing any information in, if we're not hearing individuals, we tend to be marginalized off to the side, and then we're just simply not engaging as much. And we do know that social connections is another big sort of, not risk factor, but if we have a lack of social connections, that becomes a risk factor for the development of dementia. So we want folks to get hearing evaluations. We also know that people with hearing loss have smaller brain areas in terms of the temporal lobe and areas where we form memories. So hearing is really important in order to keep those areas of the brain that form our memories as plump as possible. We want to make sure that we don't lose that area of brain volume.
What about genetics? Is that an important component?
Genetics are really important, and they're not what's called deterministic, meaning that if you have one of the bad genes, and I'll talk about that in just a minute, if you have one of the bad genes, it doesn't mean you're going to get Alzheimer's disease, again, the most common form of dementia. But if you have one of the bad genes, and I'll tell you what that is, that's the ApoE. ApoE is the gene. It encodes for a protein called apolipoprotein E, and that's a very important protein that helps to basically shuttle cholesterol in and out of the brain itself. And cholesterol is really important for the brain because cholesterol, think of it as a fatty substance, and a lot of our brain covering is made up of fatty substance, which helps protect our neurons. And we need that cholesterol in order to efficiently sort of transmit electrical impulses throughout the central nervous system or the brain. Now, the ApoE gene is responsible for that, but there's different what are called isoforms. There's no, there's no variants per se. They're all normally occurring within us, and you get one copy of the gene from your mom and one copy from your dad. So you have two different genes, if you will, and then there's the ApoE2, the ApoE3, and the ApoE4. So between 2, 3, and 4, and plus knowing you have one copy from your mom, one copy from your dad, you have 6 different combinations of the ApoE that can stratify the risk of developing Alzheimer's. Let's simplify it and just say that anyone with 3, which is the most common form of the ApoE gene, anyone with 3 is a neutral risk, neither protective nor increased risk for developing Alzheimer's disease. If you have one of the ApoE2s, that's actually protective against developing Alzheimer's disease. Unfortunately, the ApoE2 is also the least common form of the ApoE gene. Now, the bad one that people hear about is what's called the ApoE4. If you have one copy of the ApoE4 gene, you're at about a 3-time increased risk compared to the general population of developing Alzheimer's disease. If you have 2 copies of the ApoE4 gene, meaning you're ApoE4 homozygous, you are at a 10 to 20-time increased risk than the general population. But again, these are risk factors. It doesn't mean you're going to get the disease. It just means you're at an increased risk. So we want to really work hard with those folks that we know their genetics. If they have 1 or 2 copies of the ApoE4, we want to really work hard with them on lifestyle maneuvers that they can do, whether that be exercise, modifying their diet, working on their sleep, getting their hearing checked, making sure that their blood pressure and their cholesterol are good, making sure that their diabetes is under control. We want to make sure metabolically they're as good as they possibly can. And we want to make sure the things that they have control over, mostly diet and exercise, that they're really pushing themselves as best as they can to mitigate that risk if someone has the ApoE4 allele.
Well, you really touched on some key points, really, as far as preventing diet, exercise, sleep, taking care of hearing issues. Are there any other factors that you can think of that are important for, I guess, trying to lessen our chances of contracting dementia?
Yeah, there's two more things. One of them is limiting sort of risky substances. Smoking goes without saying. We don't want our individuals smoking because that increases the risk of vascular disease, and higher levels of vascular disease increases the risk of all forms of dementia. The other one are what we call social connections. So we want to make sure that individuals are active within their social circles, whether that mean going to community groups, going to religious affairs, going out with their friends, having activities with family. The last thing we want individuals to do as they age is sit on the couch by themselves in front of the television. That means a sedentary lifestyle, and that means they have no social connections. So it's really important for individuals to interact with other people because that stimulates our brain, and there's lots of data to support decreasing the onset of dementia and slowing the disease course. The other thing to really keep in mind is all of these things we're talking about, we really want to do these habits as early as possible. And the saying goes, how we act in our 30s, 40s, and 50s defines how we're going to live in our 60s, 70s, and 80s. So these are habits that are lifelong, but also never too little, never too late. So if this is something that, we haven't started until we're 50 or 60, we're not too late. That's still acceptable in terms of, again, decreasing the risk of onset of disease, or if disease has started already, slowing the progression. So social connections, really, really important in terms of slowing that onset and delaying onset and slowing the progression. And also anything that's cognitively stimulating. People often say, oh, should I stop working? Should I stop doing this? And we often counsel people, we want you doing as much as possible to really stimulate your brain. And also that it's the schedule that's really important. The aging brain does really, really well with a strict schedule, meaning waking up at the same time, going to bed at the same time, meals at the same time, and also interspersed between that time, lots of activity, whether that be physical activity or mental stimulation, but really a combination of both. The amount of physical activity that's really recommended is about 150 minutes of what's called zone 2, fairly vigorous exercise. What zone 2 means is that you're moving along at a good enough pace that you're a little bit short of breath, meaning you can talk to someone that you're walking with, but you're working. You're short of breath in doing so. So we want people moving to get their heart rate pumping, above their normal resting heart rate. And we want them a little bit short of breath in terms of that. And that's 150 minutes a week. And the recommendation would also be to couple that with at least 2 days a week of what's called, the new fancy term is called resistance training, but the old term would be weightlifting. The reason why it's more called resistance training is because some of the resistance might be your own body. That could be simple hanging from a bar, push-ups, things like that. So you really don't need any weights, so to speak, in terms of having that resistance training. It just can be your own body. So 150 minutes a week of aerobic exercise and 2 sessions of resistance training per week.
Dr. Fellows, tell us about the stages of dementia.
So the stages of dementia are most commonly associated when we go back again and talk about Alzheimer's disease. Alzheimer's disease, I tend to keep things very simple with my patients, and I call it mild, moderate, or severe. But the National Institute on Aging, in association with the Alzheimer's Association, has come up with the 6 different stages of dementia. And really what we're talking about are the earliest stages, sort of stage 1 and 2. These would be stages where the patient is perfectly normal. There are no cognitive changes whatsoever. But the individual starts to have sort of biomarker changes. And this is what's kind of scary, is that you can have biomarker changes. Remember that blood test I talked about earlier? You can have an abnormal blood test, and the most common that we're using nowadays is what's called p-tau 217. That's a fancy name for basically a highly sensitive, accurate blood test that is a marker for that amyloid deposition in the brain. So individuals start to have a positive blood test that could be 10 or even 20 years prior to the onset of clinical symptoms. So if you're 65 and the neurologist or the primary care doctor is looking to diagnose you with Alzheimer's disease, you probably had amyloid starting in your late 30s or early 40s already starting to accumulate. So that's stage 1 and stage 2. We're functioning at a perfectly high level. but there may be a blood test or a PET scan or some sort of diagnostic study that shows that there's amyloid already in the brain. And then we go to stage 3 and 4. Those are sort of the mild stages. Stage 3 is what's called mild cognitive impairment, MCI. MCI, for example, the individual still, again, functioning at a super high level. They can work, they can drive a car, they do all of their what's called activities of daily living, cooking, cleaning, paying bills, dressing themselves, putting makeup on if you're a woman, for example. So you're doing all of the activities of daily living. And then that sort of can segue into stage 4, where now it's called mild cognitive impairment secondary to dementia, in particular Alzheimer's disease, which again, both of these are still in the mild stage. But by the time you're in stage 4, you're starting to have some more significant memory problems. But really, it's just that. You're not having problems in what's called praxis. And this is really a hallmark feature of dementia. This is called dyspraxia, or difficulty in doing a task that you were really good at in the past. An example would be not just memory problems. Oh, I went into a room, I forgot what I went there for. Or, oh, I'm not getting the words out quite as fluently as I once was. These are important things, but really we get really concerned when individuals start to have problems with task-related things. An example would be driving. One time I had built-in GPS in my head, and now I'm having trouble navigating my car, and I'm getting confused and not really knowing where I'm at all the time. That's a big deal. Another example would be I'm usually excellent with my finances. I've managed my checkbook or portfolio or what have you forever. And now maybe I've made some errors or paid a bill twice or missed a bill, what have you. So some difficulty with that. Another example would be cooking, God forbid, leaving the stove or the oven on, putting your home at risk for fire. So these are the things that sort of evolve through stage 4. And then stage 5 is that moderate stage. And now we're really having problem with that dyspraxia. We're really having more issue in the moderate stage, stage 5, where there's difficulty in doing those previous tasks. And then stage 6 would be severe dementia. And now we basically not only are having trouble with doing tasks, but we're also having sort of behavioral problems. There could be more depression, anxiety, or even worse, there could be agitation, aggressiveness, combativeness, or hallucinations. And that's where individuals become more difficult to manage because we have to use a lot of rather sedating medications in order to control that behavior. That's a stage 6 phenomenon. So again, just to summarize, stage 1 through 6, stage 1 and 2, meaning my biomarker changes, whether that be a blood test or another diagnostic study, which shows that there's a pathologic feature in your brain that will lead to dementia if you live long enough. Then stage 3 and 4, mild cognitive impairment and mild dementia. Then stage 5, moderate dementia. Now, remember, difficulty with the tasks and stuff like that. Going on to stage 6, not only difficulty with tasks, but severe memory impairment and also behavioral changes.
What about treatment?
Okay, treatment nowadays is different than it once was. So we want to get people in our office as early as possible. Stage 2 to 3 really is where we want them. And what I mean by that is we want individuals that we've done the testing and we've proven the amyloid problem, which means we've proven Alzheimer's disease, and we want to make a meaningful impact for their future. There are drugs on the market now that are newer that are called anti-amyloid drugs or amyloid targeting therapy. These, as a class of drugs, are what are called monoclonal antibodies. What that means is that it's an infusion medicine and it stimulates our body's own inherent immune system, in particular in the brain and the central nervous system, what are called the microglial cells. It stimulates these microglial cells to basically come in and gobble up and get rid of all of the amyloid in the brain. Now, unfortunately, we know that Alzheimer's disease isn't just amyloid. There's other bad things going on. So we can't halt the disease. We can't reverse the disease, but we can finally slow the course of disease. And depending on the individual and the drug that we use, we can slow the course of disease by anywhere between about 25 or even 60% slowing of cognitive decline. It's very meaningful. It's not the be all end all, We call it a wonderful step in the right direction. This is stuff that we haven't been able to do ever before. This class of drugs, for example, monoclonal antibodies, are being used in multiple sclerosis and ulcerative colitis and skin conditions. So lots of different specialists use it. Rheumatologists use it for rheumatoid arthritis. Dermatologists use it for psoriasis. So these are not new classes of drugs, but we can finally target the amyloid to get rid of it. Now, the drugs are not without potential side effects. And Henry, I'm glad you brought up the genetics, because in individuals with 1 or 2 copies of the ApoE4 gene, those folks are at a higher risk for developing side effects. Doesn't mean we won't use the medicines, the anti-amyloid drugs. It just means that we have to be even a little bit more cautious in those individuals, because you can get what's called ARIA. That's an acronym that stands for amyloid-related imaging abnormality, and that can be little tiny bleeds or swelling of the brain. Now, again, most of the time that's completely asymptomatic. We do a bunch of MRIs throughout the first 6 or 7 months of treatment, and we're able to find the side effects if it occurs, most always before a patient has any symptoms. And if we need to, we stop the medication. Majority of patients still can continue on with the therapy without much problem. And our goal is to get rid of all of the amyloid in the brain, again, to help to slow the progression, not to halt the disease or reverse the disease. So we don't want any false expectations. That's sort of where our treatment is really focused on now. There's other treatments, drugs. Many of the listeners have probably heard of things like Aricept, which is a very popular drug that helps to boost a good chemical in the brain called acetylcholine. These are drugs that can manage symptoms of dementia, but they don't alter the course, meaning that they don't slow the course. They can just help the patient manage with their symptoms a little bit better. The other drug would be called memantine or Namenda, and that's another medicine. Think of that as almost like an antioxidant drug for the brain. It helps to block 2 of the bad chemicals in the brain. And again, Aricept and Namenda, we use them very commonly in many of our patients with memory disorders. But again, they just manage symptoms. They don't modify the course of the disease.
Dr. Fellows, this has been very important. We're running out of time. So in the remaining moments, what final thoughts would you like to share with our viewers before we sign off?
Yeah, I think in closing, I'm really concerned about patients in the earliest stages. Those are the folks that we want to target the most. So I think it's worthwhile to talk to your primary care doctor and talk to them about getting some of these blood tests, understanding your own genetics that can increase the risk of your own personal course developing Alzheimer's disease, and also one of the blood tests that can early look for the amyloid in the brain. Because we do know that the earlier that we're able to initiate therapy, the better impact we're going to be able to make on you. So we don't want to minimize any memory changes in our mid 60s or early 70s. We want to attack that as early as possible. We don't want to wait for that disease to progress, because at that point, it becomes a little bit too late.
Well said. Dr. Jonathan Fellows, I want to thank you so much for being our guest on Gracefully Graying. Of course, I want to thank our viewers and our sponsors and Bloomfield Cable for making this possible. This was really important. And again, I enjoyed your presentation at Temple Israel as well. And thank you so much for being my guest.